Having a child is a big decision,
I would not change for a moment everything that I had to do to bring them to this world.
especially when you think of what can go wrong.
When we found out Bryce was coming early, I was only 22 weeks pregnant.
Tonight, PBS 39 brings you a special one-hour health initiative on pregnancy and infant care. Learn what every new or expecting mom and dad need to know.
We were just scared. We didn't know how to deal with things and how things were going to work out.
Explore the best treatments for high-risk pregnancies. Plus, find out about groundbreaking innovations for treating birth defects before the baby is even born.
This year in the Garbo Special Delivery Unit, we'll evaluate about 1,500 mothers carrying babies with birth defects.
Learn all this and more tonight. This special PBS 39 health initiative is brought to you by
The people of Air Products feel privileged to bring this programming to you. By supporting education and the arts, Air Products strives to improve the quality of life here in the Lehigh Valley, where we call home.
You're safe at home at Luther Crest, a Diacon senior living community in Allentown. Our mission is to offer premier accommodations and services so residents can cultivate a healthy and fulfilling retirement. At Luther Crest, we offer independent living apartments and cottages, personal care, skilled nursing, rehabilitative services, and more. Plus, the Luther Crest team strives to provide each person family-like support. You might say it's like a home run. Luther Crest.
Thank you for joining us for this special PBS 39 Health Initiative, Pregnancy and Infant Care. I'm Laura McHugh. Every year in the United States, almost 4 million babies are born, according to the Centers for Disease Control and Prevention. This year, I'll add my first to that list. Most of these babies will enter the world perfectly on schedule and very, very healthy. But about 1 in every 33 babies will have a birth defect. The CDC reports they rank as the leading cause of infant death. But right here in our region, doctors have made amazing strides in treating these conditions before the baby's even born. Focus reporter Grover Silcox joins us in the studio with more. Grover.
Thank you, Laura. About 120,000 of the 4 million children born in the United States each year will have a complex birth defect, and about 5,500 of them will die. If they survive, they may suffer lifelong disabilities. Doctors and researchers at the Children's Hospital of Philadelphia have used the diagnostic tools developed over the last few decades to pioneer new ways to treat these defects before, during, and after birth. CHOP Center for Fetal Diagnosis and Treatment leads the way in fetal care, having performed more of these surgeries than any other facility in the nation. CHOP doctors in multiple specialties now save babies with birth defects and improve the quality of their lives before they're even born. Two patients lie on the same operating table, a mother and her unborn child. Surgeons at the Children's Hospital of Philadelphia have pioneered a way to go through the mother to repair a birth defect in the child. It's called fetal surgery.
Around 18 weeks during my pregnancy, we were informed that our son had spina bifida.
Well, spina bifida is a problem where the developing tissues around the spinal cord don't develop. The back is basically open.
Bridget Ellis's newborn son, Braden, is among 3,000 babies diagnosed with spina bifida or a similar birth defect each year. It happens early in pregnancy and can lead to enlargement of the head and paralysis.
We were shocked and had a mix of emotions.
Bridget, her husband Brad, and their children Melanie and Ryan left their home in Pittsburgh and came to CHOP to see if fetal surgery could fix the unborn child.
I had never heard of fetal surgery. You're like, what?
Well, the criteria for any type of fetal surgery is a baby with a major birth defect that is actually in risk of dying in utero, or in the case of spina bifida, has a major birth defect that will result in long-term disabilities.
This year, Dr. Scott Adzik and his colleagues in CHOP's Fetal Diagnosis and Treatment Center will evaluate about 1,500 mothers carrying babies with birth defects.
We'll do about 150 to 200 fetal surgery operations.
They'll do them for spina bifida and a wide array of other birth defects, such as urinary tract obstructions, hernias, masses on the neck, and twin-twin transfusion syndrome.
We offer pretty much the full spectrum of interventions, from the more major surgeries like open surgery for lung tumors in the fetus or tumors that are growing off the tip of the spine. From there, we kind of move down into less invasive fetoscopic procedures.
This year, CHOP celebrated its 1,000th fetal surgery patient, a national record built on decades of research and development.
About 30 years ago, new technology arrived, which was maternal fetal ultrasound. So for the first time, we could see inside the pregnant uterus.
They could also see fetal birth defects.
My colleagues and I were frustrated in taking care of babies where because of the birth defect, there had been progressive organ damage before birth that became life-threatening at the time of birth.
So they began the research, testing, and trials that led to fetal surgery.
To do an operation on the mother to get to the baby and to think you could correct something before birth was viewed as a crazy concept. But we were determined.
That determination paid off. Today, Dr. Adzik leads a world-class team of experts in repairing and mitigating the impact of birth defects through fetal surgery as well as postnatal surgery.
We met with every doctor individually. Lots of nurse practitioners and lots of testing was done.
Mothers come to CHOP's Garbos Family Special Delivery Unit for evaluation. Only 10% of them will qualify for the surgery.
The special delivery unit is set up so that the mother can have her ultrasound, and then she can have her fetal echocardiogram, which is a view of the fetal heart. And she can also have an ultrafast fetal MRI, which we developed here about 15 years ago.
The medical team explains the test results to the parents and tells them whether mother and baby qualify for the surgery. Bridget and her baby did.
We knew of the benefits, we knew of the risks. We just kept our faith and knew all along that we were making the best decision.
The surgical team performed the operation in Bridget's 21st week of pregnancy. They began with a cesarean-type incision to access the baby.
We did the repair to protect the developing spinal cord and to prevent that cerebral spinal fluid leak and to prevent hydrocephalus. And she was discharged from the hospital after about 4 days.
Bridget delivered by C-section 10 weeks later in CHOP's Special Delivery Unit. The baby came early, which is a risk factor in fetal surgery.
The CHOP staff here is unbelievable. The fetal program, the special delivery unit, from the nurses to the techs, it's all the way up to the surgeon. I mean, they are like family.
Braden will remain at CHOP working through certain preemie issues while his family stays by his side. Dr. Adzik is optimistic about his future and the future of fetal surgery.
I think we'll do more things minimally invasively, just like we do in children by laparoscopy.
CHOP researchers are exploring the idea of an organic glue to bind the gap in spina bifida laparoscopically without the need for a large incision.
Stem cell transplantation before birth to treat blood disorders, for instance, is pretty near term. A fetal gene therapy, that will not be ready for prime time clinically for a while, but that's very intriguing if you could treat cystic fibrosis, say, before birth with a cure. That'd be pretty powerful.
And a child who may never know what it's like to need a wheelchair. That's pretty powerful, too.
Thanks, Grover. To continue this conversation, I'm now joined by Dr. Jim Araldi. Dr. Araldi is the Clinical Director of Prenatal Services at St. Luke's University Health Network, as well as the Chairman for Obstetrics and Gynecology. Welcome to the show.
Thank you for having me.
We just saw how many birth defects are treated in these amazing miracles, but how are they actually diagnosed?
Well, pregnancy care first starts for us at about 12 weeks. We try to look very closely at babies at around 12 to 13 weeks, looking for birth defects that can be diagnosed as early as that time. So there's a very early targeted ultrasound which starts at that time, where we're looking at baby from head to toe. Granted, we can't see all birth defects at that point, but a lot of them we can pick up on. And people appreciate that. They want to know right away, what am I looking at? And then, where do we go from there? So we start with a targeted kind of early ultrasound. There is also at that time, chromosomal or Down syndrome screening that we also offer at 12 weeks as well. Now, Down syndrome or chromosomal abnormalities, only a couple of them increase with maternal age. Does not have to do with paternal age, dad's age, although there's some recent article in the journal Nature that looked at maybe paternal age increasing the risk of autism. And we won't get into autism tonight, but that's a huge another...
Right, that's technically not considered a birth defect at this point.
But there's non-invasive screening at 12 weeks. There's blood work. The old days we used to use what was called the triple screen, then it became the quad screen. The detection rate for Down syndrome is 85% for that blood test alone. We have gotten better though. So now there is the sequential screen, which includes looking at the little water space behind a baby's neck called the nuchal translucency and blood work. And with that, for both blood work at 12 weeks and another round of blood work at 16 weeks, we're up to 91 to 95% detection rate. Now, when I say detection rate, what I mean, if the baby truly did have it, the ability of the test to pick it up is 95%.
Now, who should actually get these screenings?
Well, it's a great question, Laura. I think we have to remember that the risk of chromosomal abnormalities increase with maternal age. However, all women are technically at risk because Down syndrome, most of them are just spontaneous events. And when you look at who has more Down syndrome babies, it's actually younger women because they're having more of the babies. But when you look at the actual numbers, the risk of Down syndrome, for example, at, say, your 16-week time period for a woman that's 35 is about 1 in 270. And that increases. When they're 40, it's about 1 in 100. So those risks do go up as a mom gets older. Our national guidelines suggest, though, that these tests should be offered to every woman because, in theory, you just can't predict this.
How is insurance coverage with a lot of these tests? Yeah. Because it can get expensive if you don't have insurance coverage.
Yes. I think just about all insurance coverage companies cover the sequential screen, which is the nuchal translucency and the blood test. Now, if that test is abnormal, then there comes up to other options as well, which in coverage has been a little bit of a sticky point for a couple of these tests. But the biggest one that's come up recently is this non-invasive blood test that detects fetal cell-free DNA in maternal circulation. And its detection rate for Down syndrome is 99.9%. So it's really a good test. A couple of points about that, though. Not every insurance company covers that test. It's about $700 test out of pocket. And number two is if that test does come back positive, we usually follow it up with an invasive test like an amniocentesis. The days of amniocenteses are really going away, though, because number one, it's a little bit risky. Women don't want a doctor to stick a needle in her abdomen if they don't have to. The risk of losing the pregnancy due to the amniocentesis is about 1 in 700, but it's not scot-free. So to us, why not do this non-invasive test? So the only issue really that's come up with that is who is a candidate for these new tests. This is called the cell-free DNA in maternal circulation. And there's many companies out there that are doing it in today's world. There's national guidelines. So if you've had a prior child with a chromosome problem, if you're over 35, those are some of the bigger ones. If there's an abnormal ultrasound finding, like the water space at 12 weeks is too big, if you pick up a birth defect, certain birth defects have higher rates of associations with chromosomes. So there are national guidelines as well.
Thank you so much for sharing this great information. Now, we're actually about to meet one, or I should say 2, of your patients in this very next story. When we talk about pregnancy, we often reference months and weeks, but in fact, days matter when you're at risk for preterm birth, which affects almost 500,000 babies each year and ranks as another leading cause of infant death. A baby is considered premature if born before 37 weeks of pregnancy. Well, for reference, that's right about where I am now. Research tells us the longer babies can stay in the womb, the better their chances of survival. In fact, between 23 and 26 weeks, the March of Dimes reports every single extra day they can spend inside mom increases those babies' chance of survival by 2 to 4%. In this story, you'll meet 2 adorable preemies who, without Dr. Ivaldi's intervention, may not be here today.
At almost 2 years old, twin girls Natalie and Lindsay Saporowski keep their parents on their toes.
They're wild. They're getting to be real toddlers.
Walking, talking, and hitting all their major milestones, adventurous Lindsay and not-so-camera-shy Natalie are right on track with their height and weight, too. According to Mom Kate and Dad Paul, it's nothing short of a miracle.
They're little fighters. They really are.
Lindsay and Natalie inherited that fighting spirit from their parents, who went through just about everything you can imagine to bring them safely into the world.
The infertility to the premature labor to premature infants, every stage of that hits you like a ton of bricks when you're going through it.
Conceived through in vitro fertilization, these teeny twins looked primed to make a very early arrival.
At 18 weeks, we found out that she had cervical funneling, so she figured it was just back pain with the extra weight, but it was actually signs of preterm labor. It's at that time when we saw a shortening of her cervix. It got from 31 millimeters down to 25, down to 9, down to nothing.
They were not viable. I was only 18 weeks pregnant.
By all accounts, much too young to survive.
24 weeks is where we can start to feel a little bit more confident that the baby can, survive with a greater than 50% survival rate, and that they can have a good outcome long term.
So to me, I always ask myself two questions. Number one, if the cervix is showing signs of weakness, what do we do to keep these babies inside? And number two, what do we do to get them ready for a potential early birth?
After careful consideration, Kate and Paul tapped St. Luke's University Health Network's Dr. Jim Araldi to perform a special procedure called a cerclage. He placed several stitches in Kate's cervix and, combined with medication and weeks of bed rest, kept those twins inside for another 10 weeks. At 28 weeks and 6 days, Natalie and Lindsay were born.
Natalie was 2 pounds, 14 ounces, and Lindsay was 2'6". They were tiny. They were really, really tiny.
So tiny, they spent the next 6 and 7 weeks in St. Luke's neonatal intensive care unit. Under the care of Dr. Migdalia Resto and nurses like Renee Yatsila, the girls began to breathe and eat on their own.
We don't want just babies to survive. We want them to survive and live a happy life.
That's our goal. Our goal is to get these babies healthy and home to their parents. And it's so rewarding to us to see them come back and be healthy and happy.
By the time they left the hospital in late November and early December, Natalie and Lindsay weighed in at 5 pounds and had already overcome odds that at times seemed insurmountable.
They were 5 days old when I was able to hold the two of them, and it was just priceless. I would not change for a moment everything that I had to do to bring them to this world.
They're a case that I'll always remember for as long as I live, just because of the relationship we built over those weeks. They've touched my soul. Yeah, they really have.
Now, Kate had a couple of risk factors that made her pregnancy high risk, including the fact that she carried multiples. To help us learn more about high-risk pregnancies, Dr. John Smulyan joins me now. Dr. Smulyan is the Vice Chair for Obstetrics and Gynecology at Lehigh Valley Health Network, as well as their Director of Maternal Fetal Medicine. Thanks for being on the show today.
Thanks for having me.
Can you help us just by defining what high risk means?
High risk is not a diagnosis. It's not a condition, it's not a disease. It's actually a descriptive term that applies to women who are pregnant or who are considering pregnancy, who have something about themselves or their health that might increase the chances of having a particular problem during the pregnancy.
So what are some examples of the most common causes of a high-risk pregnancy?
So one of the more common causes in the United States is actually the trend towards moms having delayed childbearing. So moms can be a little bit older, and in fact, probably 30 or 40 years ago, the number of women who were 35 years of age or older having a baby was maybe about 5%. It's over 15% now. So as you get a little bit older, you have a higher chance of having other health issues such as high blood pressure, diabetes, and there's also an increased chance of the potential for a genetic problem with the baby.
Why does 35 seem to be that magic number?
It
doesn't seem that old to me.
It's not old. It is a statistical point where the chances of a problem, particularly related to genetic issues with the baby, starts to increase a little bit faster than for younger women. If you go back, though, to younger women, if you are 25 years old, you have a little bit higher chance of having a problem than if you're 20 years old. If you're 30 years old, you have a little bit higher chance at 25. 35 seems to be a point where we consider it's worthwhile at that point to start perhaps doing some extra testing or counseling or looking a little bit more carefully at those pregnancies.
So what are some of the other common causes of a high-risk pregnancy besides age?
In this day and age, moms who become pregnant are a little bit different than what we used to say. We used to say if you had diabetes, you shouldn't get pregnant. Oh. If you had high blood pressure, you shouldn't get pregnant. If you had a condition like lupus, an autoimmune disorder, you shouldn't get pregnant. In this day and age, actually, we have the ability through a variety of monitoring strategies as well as treatments, medications, that we can actually control the mother's condition and improve the pregnancy outcome for both mom and baby. I mentioned before the mom's age. That is not a condition or a disease. It's actually a point where we look closer at the mom and watch them a little more carefully. The one thing that's very, very important is that moms who have had a problem in a previous pregnancy are much more likely to have the recurrence of a problem in a next pregnancy. So those pregnancies are particularly carefully watched and monitored for the potential for a worsening health condition of either the mom or the baby.
Now, how common is a high-risk pregnancy?
It depends on which risk factor you're talking about. So in general, probably about a third of pregnancies wind up with something that puts them in a higher risk category.
That's higher than I would have expected.
So it's a surprise to a lot of people, but to put it in perspective, if you are higher risk for a problem for the baby, like a genetic problem or a birth defect, if during the evaluation we don't find that and we're very reassuring and the baby's okay, you're no longer a high-risk person. So we can actually resolve some of these high-risk issues pretty quickly during pregnancy and give reassurance to the mom and dad, of course, that everything is good. So part of the job during pregnancy of the obstetrician, the healthcare provider team, is to address these high-risk issues and hopefully put them to rest early on.
Which leads me to my next question. I don't know if is it the right word to call them treatments? What are the best treatments with the best outcomes for mom and baby?
So probably the most important thing we do in a pregnancy that has a higher chance of a problem is determine the best way during the pregnancy to minimize the impact of that high-risk situation on the pregnancy. So, for instance, with diabetes in pregnancies, it might be using medications such as insulin to control blood sugars. In high blood pressure conditions, we use high blood pressure medications. There's some that are good to use in pregnancy, and there's some we like to avoid. So it's important to work with the team to do that. We get into a little bit more complicated conditions like heart conditions and kidney conditions, and you really need a team of people to address the healthcare potential for a problem. But probably the most important thing we do with these pregnancies is judge when the best time is to deliver the baby. So the timing of the delivery becomes one of the most important things. Leaving a baby in too long in some circumstances can actually increase the chances of a problem for a baby.
Too long as in past the due date? Or?
Sometimes past the due date, but we know in moms that have worsening blood pressure problems, sometimes we're actually required to deliver preterm so that we can preserve the baby's health and the mom's health. And one of our goals, of course, is to prevent stillbirth. We're not able to prevent every stillbirth, but we have reduced the chances of that in this country remarkably in the past 20 to 30 years.
Well, I know we're just about out of time, but I have to ask you about bed rest, because my research has shown me that bed rest as we used to know it, it's really changed. It's a lot different today than it used to be.
So bed rest is a complicated issue. It is a kind of an emotional issue because the idea of a woman who's pregnant, I am high risk, therefore I need to rest at home, seems like a natural conclusion. And what we've learned over the years is that routinely putting women at bed rest during pregnancy does not seem to improve the pregnancy outcome, and in fact may increase the chances of some complications.
Well, thank you so much, Dr. John Smulyan, for all this great information.
Thank you.
While some first-time mothers may face other social and environmental risk factors, such as income status or age, with more on a national program designed to help these moms, Focus reporter Brittany Garzillo has a special guest in the studio. Brittany?
Thanks, Laura. Nurses with St. Luke's Nurse Family Partnership help first-time moms who meet special income guidelines get ready for baby's arrival. Program manager Sarah Klingner joins me now. Sarah, thank you so much for being here with us today.
Thank you for inviting me.
So tell me a little bit about the Nurse Family Partnership and how you help educate moms.
Nurse Family Partnership is a very special program. It's actually nationwide. We are one site here in the Lehigh Valley. And we work with first-time low-income mothers from early in pregnancy and continue until that baby is 2, so for 2.5 years. And we work with them to meet 3 separate goals. The first is improve pregnancy outcomes. We help mothers make good preventive health decisions, prenatal care starting early, good diet, and stopping the use of cigarettes, drugs, alcohol. The second is improving the baby's outcomes in terms of health and development. So we work to help her make good decisions for feeding the baby, for care of the baby, and even for seeking good child care. And the third is improving the family's self-sufficiency through helping her and her family make good decisions as far as long-term goals. What is it she wants to do with her life, and how can we help her get there?
Now, who's eligible for this program?
Women early in pregnancy, women who meet those certain income requirements, which is categorized as less than 235% of the federal poverty guideline, and women having their first child.
What ages do you see? Because at first I thought this was just young moms, but that's not true.
No, it's not. Actually, the average age of our client is 19. However, we have mothers as young as 14 and as old as 37 currently in Nurse Family Partnership.
Where in the Lehigh Valley are you serving the most?
Well, we serve the entire Lehigh Valley from this site of Nurse Family Partnership. We have families as far out as Trexlertown, as far north as Bangor, Roseto. We have 11 nurses who do this work. We serve 250 families.
Wow.
And of course, as one family graduates, we enroll another. So it's working continually, year after year.
Why do you think it's so important to have a program like this in our community?
We help serve a very specific group to improve their outcomes. Young moms and older moms who are in Nurse Family Partnership are there because they realize that they need some help. And it may be that they know nothing about babies, and we hear that a lot. Most mothers will tell us that they really want to be the best mother possible. They want to have smart babies. They want their kids to be successful in school, especially if they weren't successful in school. They want a better life for their child.
What sort of improvements are you seeing in the lives of both the mother and baby?
Well, one of the big benefits to us of being in Nurse Family Partnership now for 12 years is that we have long-term relationships with some of our graduates. And we have mothers now who are teachers, we have mothers in business, we have mothers who are in the community as therapists and counselors. And we actually have grown several nurses who have expressed interest in coming back and working with Nurse Family Partnership.
Now, a lot of moms, they're having their first baby. They have so many questions before the baby even arrives.
Right.
How do you work with them with that?
Oh, that's exactly why we start in pregnancy. because mothers have so many questions, and not only about their health care, but about what to do with an impending baby, that we are there, that nurse is there every week, every other week, to help the mother meet her goals of what she wants to know about her pregnancy.
Now, finally, how can people get in touch with you and learn more?
It's easy to call me. My phone number is 484-526-2778. We are part of St. Luke's Health Network. You will find us on St. Luke's website. And we're here. Many women find out about us through their physicians. And so at those prenatal appointments, by all means, ask your provider.
Sarah Klingner from St. Luke's Nurse Family Partnership, thank you so much for sharing this wonderful resource with us.
Thank you, Brittany.
Laura?
Thanks, Brittany. If you're just joining us, we've devoted this 1-hour health initiative to pregnancy and infant care. For about 15% of couples, the challenges start before the baby's even conceived. Most couples get pregnant within the first 6 months of trying, but many factors play a role in fertility. Joining me is Lehigh Valley Health Network's Dr. Wendy Schillings. Dr. Schillings is an OBGYN and reproductive endocrinologist from Reproductive Medicine Associates of Pennsylvania. Dr. Schillings, thanks for being on the show today.
Oh, thanks for having me.
Now, we got to know each other well when I was going through my own struggles to conceive, and I think a lot of people out there don't even realize how common infertility is. How common is it?
It's 1 in 6 of all couples. And the younger you are, the better chances you have, but especially as women age, it does get more difficult.
Define infertility for us.
For women under 35, we define infertility as inability to conceive for 1 year. If you're over 35, we do suggest that you start seeking help after 6 months.
But most couples do conceive within that first 6 months?
Over 50% of couples will conceive in the first 6 months, and over 85% of couples will conceive by a year.
So what are some of the most common causes of infertility?
The most common causes of infertility are actually male factor for men or tubal factor for women. Also, ovulatory problems where women aren't able to ovulate an egg, that would be the other common factor.
Is there a single most common one?
Both male factor and tubal factor are the two most common.
So when you're talking about male factor, are you talking about low sperm count, or is it a number of factors?
It can be a number of different factors. It can be low count, low motility, and there's also something called morphology, which also may be low. Men can have infections, so those are the most common reasons for men.
And the women, you talked about tubal factors as well as ovulation problems. Could you go in a little more detail about those?
Ovulation problems occur when a woman doesn't have regular cycles. So we check a lot of hormonal values to see if we can find a specific problem causing the ovulation problem. As far as tubal factor, things that make you more likely to have tubal factor is if you ever had a past infection or a surgery, or if you have endometriosis. So we do a test called a hysterosalpingogram to test for tubal factor.
When you say tubal factor, is that a blockage?
It's a blockage in the fallopian tubes. It also can be adhesions of the fallopian tube so that they're not able to move and pick up the egg from the ovary.
In my own journey, I learned that some of those are more treatable than others. So what are the most common treatments, and what can women and men and couples in this position do to help?
First, we can try easy treatments. If we find a specific hormonal problem, we can just treat that specific hormone, such as thyroid disease, because that can cause ovulatory problems. However, if we don't find a specific problem, then the goal of our treatment is to get more eggs closer to more sperm. So treatments that we'll use are ovulation induction, where we can actually super ovulate the woman to give her 1 to 3 eggs. And we can also put the sperm there at the right time.
Is that what's called IVF or IUI? We hear a lot of different terms.
Sure, there are lots of alphabet
soup.
Alphabet
exactly.
soup. Intrauterine insemination is where we take the sperm and put it directly into the uterus. We do ovulation induction with either an oral medication called Clomid or injectable FSH medications. So those are simpler treatments. Those are not in vitro fertilization. In vitro fertilization is where we actually take the egg out of a woman, take sperm and mix it with the egg, get embryos, and then put the embryos back into the uterus.
So which treatments have the best results for mom and dad?
Well, the highest success rates are with the most advanced treatments with in vitro fertilization. But I stress that not everybody needs those treatments. But we have 70% success rates in women who are less than 35 at this point.
Things that go with infertility, in addition to all the medical testing that you'll have to go through, in addition to all the decisions you're going to have to make, it takes a serious emotional toll.
It does.
On a couple.
It does.
What do you see in the patients you're working with?
Well, every patient is different, and they all go through their own struggles. Patients with infertility, first they have to decide how much treatment that they want. Also, both partners have to be on the same page. So we stress that couples talk a lot during this time period. And we want to give couples a lot of hope. As you go through the process, it's a lot of time and energy. But we try to do this in a nice, relaxed setting in our office, so when you come in for the many appointments, you're as relaxed as you possibly can be.
And it is many appointments.
It is for the more advanced treatments. During a cycle of IVF, you may be in for 7 or 8 ultrasounds during that time period. Other treatments would be less, 1 or 2 ultrasounds.
So there's a lot for couples to consider. There's a lot of moral considerations as well as a lot of considerations about the expense that goes into a lot of these procedures, right?
That's true, but what I try to tell couples to consider is, first, we will try the easier things first. But if they haven't conceived in over a year, a lot of people would spend that much on a child. Granted, it's a lot easier to spend on a child than a potential child, but still, there's a lot of science out there that can be very, very helpful.
Dr. Schillings, any last words about infertility while we're talking about it?
I would just say keep up the hope. As you know, it can happen, and it does happen often. So just decide what you want to do, and we'll help you with it.
Dr. Wendy Schillings from Reproductive Medicine Associates of Pennsylvania, thank you so much for being here and sharing this great information with our viewers tonight.
Thank you so much.
Well, conceiving through assistive technologies such as IVF can put a mother at higher risk for preterm birth. I've had many parents tell me you're never really ready for kids, but for some, that's much more true than others. Let's head over to Focus reporter Brittany Garzillo to learn more. Brittany.
Thanks, Laura. Well, pregnancy is generally a time filled with joy, as most parents anxiously await the arrival of their newborn baby. But there are times where that little one is ready to face the world a little too soon. According to March of Dimes, 1 in 8 babies in the United States are born prematurely. Babies who are born at 23 weeks of pregnancy have only a 30% chance of survival, turning the lives of many families across the country upside down. Today, there is one hospital in our community that is trying to help ease the pain for parents of premature infants. Take a look.
Weighing 10 pounds, baby Bryce Cunningham may look like he was born only a few weeks ago. But in fact, Bryce is 5 miraculous months old.
When we found out Bryce was coming early, I was only 22 weeks pregnant.
She delivered on February 28th, and it was supposed to be June 17th.
When he came, he was 1 pound 9 ounces. His head was the size of a clementine.
Today, the Cunninghams reunite with staff at the Lehigh Valley Health Network's Neonatal Intensive Care Unit, or NICU for short. This team of doctors and nurses helped Bryce to continue growing big and strong during the 3 months he spent practically confined to one of these tiny isolettes. Kristen says Bryce was so tiny, she couldn't even hold him.
Oh my gosh, he's 10 pounds! Wow, you look so big! Bryce, he's a big boy.
For most parents of premature infants like the Cunninghams, life in the NICU consists of waiting days, weeks, and even months just to hear those sweet words that they can finally hold their baby in their arms and return home. With a preemie, an hour can seem endless, each day an eternity. Now, thanks to technological advancements, parents of premature infants like Kristen and Jason can see a whole different picture.
This technology is great for our parents, because the hardest part of being a new parent is leaving the hospital without your baby, who's in the NICU for days or months for some of our babies.
The only thing that gave me the peace of mind to know that everything was going to be okay would be when I would walk out the door, I know that I could put him up on the screen.
It's possible because of Lehigh Valley Health Network's BabyCam Angel Eye system.
And there he is. And if I want to take a picture of him, just take a picture of him.
So the BabyCam is a new technology that we have here in the NICU, which is a camera mounted to the isolettes as a way for the parents to continually be able to see their baby when they can't be here.
Parents receive an access code to log into the BabyCam website. They can share that code with family and friends so they can view their child 24 hours a day in real time on any devices with internet capability, completely for free.
BabyCam, right there.
The technology was developed by the University of Arkansas for Medical Sciences, and the Lehigh Valley Health Network is its very first partner.
All of us were hesitant when we heard the University of Arkansas was, offering us this technology because it's not been anywhere else that any of us have been.
Because the hospital was only offered a limited number of baby cams, they chose to mount the cameras on the isolettes that are home to the NICU's most critical patients.
We only have 9 right now, and when their baby does grow out of this isolette, they're very disappointed that the camera cannot follow their baby until they go home.
The baby cams also serve as a resource of information for families who are watching at home.
They would put signs up that would say, please excuse me, I'm having routine testing. It really helped for us to know when to call rather than to be calling every 5 minutes.
I think the phone call, the nervous phone calls from the parents that the baby's okay, has dropped tremendously because they can see that the baby's just sleeping there.
When I do wake up in the middle of the night and just wonder what he's doing or how he is, I immediately log on to the internet and see him.
For first-time parents, Lori and Kyle Johnson of 40 Fort, Pennsylvania, these webcams provided a brief but welcome relief from the emotional roller coaster of life in the NICU. Their 26-week-old son Johnny arrived over 3 months early.
When Johnny was born, he weighed just 2 pounds. That's about the same weight as this water bottle and less than 1/3 the weight of an average newborn baby. But now, thanks to the BabyCam software, Johnny's parents are able to view him grow even when they aren't in the hospital.
My husband just ran up into my room and said, we have access to see Johnny 24 hours a day, and so he showed me the website, and it just made my day.
She doesn't have to call, she doesn't have to do, she can just look and see sleeping, good, and she can go back to sleep.
It just gives me so much sense of relief.
This sense of relief extends beyond Lori and Kyle to the entire Johnson family, even the ones who live almost 2,000 miles away.
They all live in New Mexico.
It's been very good for our family that's so far away to be able to have that connection.
My mom takes it to the beauty shop and shows the beautician and all her friends that she meets there, and she loves showing off Johnny through the webcam.
As you can see, it goes way across the United States, probably into some different countries.
The Lehigh Valley Health Network plans to add additional cameras in the future so that more families with premature infants can view their children right in the palm of their hand.
I think, being in the NICU is in and of itself a whole different world. I mean, we're sort of a closed unit, and so people can't really appreciate, I think, how important this technology is for our families unless you've been in their shoes.
Not everybody gets to see their baby literally grow in front of their eyes. You wouldn't want your baby to be anywhere else but here in the NICU because they have 24-hour care and you can trust them.
For all families with preemies, every breath, every minute, and every day is a miracle. And now at the Lehigh Valley Health Network, technology captures every precious moment of it.
Thanks, Brittany. Many families report that having a preemie or a child in the NICU changes their lives forever. That's certainly the case for our guest Susan Drexinger-Abelhuda and her 11-year-old daughter, Catherine. Thank you so much for being with us yet again today.
We're very happy to be here.
Now, we've been following Catherine's progress with our PBS 39 cameras since she was just a few weeks old. Here, take a look.
Our cameras first captured the Abelhuda family in 2002 as they spent their first moments together as a family of 4. At the time, baby Catherine, just a few weeks old, remained confined to Lehigh Valley Health Network's neonatal intensive care unit.
To see her in a flat bed that's covered with a clear plastic, and of course the tubes and the IVs and everything, and she's just this tiny little 12-inch baby. But everything's there. All 5 fingers were there, all 5 toes. You could see her heart beating. You could count every little bone.
When Catherine was born just 24 weeks into Mom Susan's pregnancy, she weighed 1 pound, 10 ounces. Her teeny tiny feet weren't much bigger than Susan's fingerprints.
Well, my first thoughts were obviously her survival, because 24 weeks is a very gray area for their lung development.
By age 3, Catherine was running full steam ahead, meeting major milestones and lighting up her parents' lives.
You would never know that she ever was 4 months early and that she was ever 1.5 pounds when she was born and 12 inches long. It's quite an amazing transformation over the last 3 years.
She's running, she's fighting, she's enjoying life, and it's a truly amazing thing to see those things happen.
At age 5, Catherine became a nationwide symbol for survival as the Abelhudas traveled the country as the March of Dimes 2008 National Ambassador family.
Thank you for being a champion for the babies and help the March of Dimes.
We actually speak on behalf of thousands and thousands of families who have preemies, who can go out and talk to CEOs and say why it's important. We speak on behalf of the babies that made it and the babies that didn't.
Catherine dances her way through a healthy, active life. Susan and Michael still put family first and remain committed to sharing their story as a way to help other families with premature babies.
Susan and Catherine, thank you so much for being with us yet again today. Watching that video, Susan, how has this changed your lives, that experience you had 12 years ago now?
Well, great memories are flashing through my mind right now. And really, when a child is born as tiny as Catherine was, it's just hard to believe that she will ever turn out to be this amazing little 11-year-old now. However, through the journey, it really took its toll on as a mom and a dad and a family. Everyone has to work together to make this little baby come home at the end of the NICU stay.
You know, I've heard doctors say that they're sort of the coaches in the process, but you guys are the quarterbacks making it all happen.
That's right. And the nurses and the respiratory therapists and everyone involved, all of the healthcare professionals really bring these children home to their families. And every one of them knows when it's the right time to talk to you as a mom and when it's the right time to just let you kind of have a minute with your child. And every day goes sometimes really, really fast and sometimes a little slower when you have a little bit more stressful news along the journey.
I can imagine some days it's, minute to minute, hour to hour. Mm-hmm. Catherine, today, do you have any lasting effects from being born so early?
Well, besides my mom telling me and my IV marks on my arm and legs, we have a dog, and he was really small. He was like the runt of the litter, so he was really small too, and it's just like he looked small like I did.
So you have a special affinity, I'm sure, for the run of the litter. Are you, on pace with your peers today? Like, when did you catch up to your peers with height and weight and everything?
Like 2. I think. I'm pretty sure it was 2.
And how do you measure up today? Yeah, on the taller side or the shorter side?
I'm on the taller side.
On the taller side here?
Most people.
What was that milestone like at 2 years old when she finally was advanced and developed to the point of all of her peers?
Well, when the doctor tells you when a child is 2 years old, you're going to double that height. And I was like, wow, from 12 inches long, a little ruler, to, they said she'll probably be about 5'10" when she's finished growing. But her legs are long and everything's all wonderful. But it's hard to believe when they're 2 years old, oh, yeah, she'll be about 5'10", and to know where she kind of came from so tiny. And it's pretty amazing.
How do you remain active with the March of Dimes today? I know you were the ambassador family about 7 years ago now. Share with me how you're involved today.
Well, we still are very involved with the March for Babies, which, of course, is the big spring walk that we do every year. It's Walking for Catherine because we are there to help and inspire other folks to join in the walk. And this past year, it was the 75th anniversary of March of Dimes. So all of the local ambassador children all sang happy birthday to March of Dimes before we headed out on the walk. And it was a beautiful, beautiful day. And it's incredible, too. In the fall, there's a great signature chef's auction. So we get to go there and help test food and talk about all the great things that the March of Dimes do for families. And that's really what it's all about, learning about how to be a good mom and how to have a healthy baby.
And you stay involved with them, too, Catherine? Going to all these events?
Walk with them, and I go to the chef auctions too, and I get to see the people that helped me, and sometimes we visit the hospital and we give brownies to the nurses that helped us. So
some of the same nurses are still there.
There are. And we at the walk we always see our neonatologist, Dr. Zelinka, who was absolutely amazing in helping her to come home to all of us.
Now, we saw in the piece earlier that they now have these angel cams in the isolettes. I mean, you know what this must mean to those moms.
It must be incredible to know that you can just, anytime, day or night, you can go and pull it up on your computer and be able to see this little, precious little angel. We could go anytime, but it's not always easy for families to go into the NICU
Well, and you had Michael at home.
Exactly. And he was only 6 at the time, so, it's a little different when you have a child at home. And some families don't live right down the street from the hospital, so it's a great, great gift that the hospital is giving the families.
And so, of course, now Michael's looking at colleges. We've gone full circle.
Mm-hmm.
What's the number one piece of advice you have for a family with a baby in the NICU right now?
Take every minute and every day. Just slow down, and it will be okay. You just have to listen to what your doctors and your healthcare professionals are telling you. Read a little bit, learn. Obviously, there's great, great information, wonderful programs like this, but really just take every day as it comes, and you'll get through it.
Great advice from a mom who's been there. Thank you so much, Susan and Catherine, for giving us this kind of unrestricted access for many, many years now.
Well, thank you, and thank you for helping the community learn more about how to have a healthy pregnancy.
For more information about prematurity and many of the other topics we've explored in this program, visit marchofdimes.com. Finally, we turn our attention to sudden infant death syndrome, commonly known as SIDS. The CDC ranks SIDS as the leading cause of death among infants ages 1 to 12 months old. So what is it besides every parent's worst nightmare? Well, to answer that question and more, we have NICU nurse Kathy Vicko from Easton Hospital. Kathy, thanks for being with us today.
Thank you for having me, Laura.
So what is SIDS?
SID is known as crib death. People relate to that term, but it's sudden infant death syndrome. It's the leading cause of death for infants from 1 month to 1 year old.
And so there's actually a lot you can do in the crib to reduce the risk of SIDS, but first tell us what are those risk factors for SIDS?
Well, there's a few risk factors that we know, but we're not sure of any. There's no individual cause or no known cause of sudden infant death syndrome, but there's ways that we can prevent SIDS from happening to babies, and there's a campaign started in 1994 by the American Academy of Pediatrics called Back to Sleep. And actually, back in the day, we thought putting them on the belly was the way to put them.
Right.
And
that's probably the way that I was raised. I was probably raised on my belly.
That's right, because they thought when you spit up, your head was facing down. But in actuality, there is no proof of babies choking on their back. So proper positioning is
I was going to say, so we couldn't bring in a crib today, but we do have a pack and play because that's where a lot of babies nap. So show us what's right or wrong with the way we have the pack and play set up right now.
The pack and play is great, and also with cribs, we don't recommend bumpers. There's no evidence proving that bumpers prevent injury. So a non-cluttered crib. We all like baby stuffed animals, blankets, and fuzzy pillows and pretty comforters, but actually nothing in the crib, just on their back. And now they have sleepers out there that we didn't have many years ago, but now we have. And actually, a lot of them put back to sleep to remind parents to put the baby on their back. This replaces a blanket. So we don't recommend blankets in the crib.
So let's get rid of the blanket,
get rid of the blankets, get rid of the stuffed animals.
Get those out of here.
Get rid of the mobiles, anything that the baby can get to, and just keep the area safe and open.
So you want nothing in the crib
Nothing in
but
the
baby.
crib. Nothing in the crib but baby. And a lightweight blanket and nothing heavy. No soft mattress. It has to be a nice firm mattress for the baby with tight-fitted sheets. And that is it.
And so how long are you putting the baby on the back?
Well, babies typically turn from the age of 4 to 7 months, and if they turn on their own, that's okay. But the risk is primarily from 1 to 4 months of age, and as they get older, the risk lessens up until a year of age. Also, pacifiers, believe it or not, people always didn't want to give pacifiers, and there's been studies saying pacifiers, not on a string, loose, prevents SIDS.
Okay, and so if the baby does roll over on their own, we don't have to get up in the middle of the night. We check the video monitor, we run in.
That's right.
It's okay to let the baby continue sleeping on their belly.
That's right. You let them be.
And show us these wearable blankets. So we have to pick them up because I know a lot of, let's pick the baby up and show people because this is the best option for you because you can't have a blanket, right?
That's right. And actually, they have the zipper that comes from the bottom, and you zip up, and it's like a sack, like a sleeping bag, and their arms are free, and it just keeps them warm. You want to dress them as comfortable as an adult with a sleeveless shirt. That's how you keep the room. That's another risk, hot rooms, to make the room nice and comfortable, not overheat the baby. It makes them too sleepy, and you don't want that.
Okay, so what else should parents know about SIDS? It's not terribly common, right?
It's not terribly common, but it's good to educate parents today and let them know that it is there and we can do anything to prevent it. We're ahead of the game.
Kathy Bicco, thank you so much for joining us today.
Thank you so much for having me.
We hope you'll tune in Friday, September 20th at 7 p.m. for the premiere of our newest PBS 39 program called Focus. Our award-winning team will bring you the stories showcasing the people, places, and issues that matter to you. Plus, don't miss the next installation of our Emmy-nominated Focus on Health series. We'll focus on breast cancer in this special night of programming. That's coming up Tuesday, October 15th, starting at 8 p.m. So it's one that you're not going to want to miss. Grover and Brittany are here to tell us more about what they're working on. Grover?
Well, I'm going to take a comprehensive look at diagnostics, from self-examination to mammography to the latest in technology to detect breast cancer.
And Brittany, what do you have?
And I'm working on a story about prophylactic mastectomies. It's a preventative surgery option for those who are at high risk of developing cancer.
And that's what Angelina Jolie got a lot of press about in the last several months, correct?
Exactly.
Great. And I'm actually working on a piece about life after cancer, so we'll learn more about those conditions that linger long after you get that great news that you're cancer-free. Should be another great show. Well, from all of us here, thank you so much for joining us for this special PBS 39 Health Initiative.
This special PBS 39 Health Initiative is brought to you by
the people of Air Products feel privileged to bring this programming to you. By supporting education and the arts, Air Products strives to improve the quality of life here in the Lehigh Valley, where we call home.
Our pediatric dentist